Welcome back to Kinesthetic Knowledge on Record. I'm your host, Isha, and today we will be discussing muscle weakness, looking specifically at arthrogenic muscle inhibition. So let's get started. So I recently had a conversation with Jay to discuss her knee injuries, particularly focusing on her ACL injury and surgical repair. Unfortunately, she was unable to join us on this podcast, but she did provide us with an audio discussing her experience. A full version of Jay's side of the story is posted on her TikTok, which will be linked in the description below. But for our purposes, let's hear a clip of her explaining her injury now.
So a little bit of history about surgical reconstruction. When an ACL is completely ruptured, meaning a full tear across the entire ACL, surgeons have found that it's a lot more effective to use a graft as the new ACL rather than suturing or reattaching the old ACL. They found that this solution has a lot more longevity, structural integrity, and tensile strength, whereas a suture or a reattachment of the old ACL resulted in more frequent re-injury. In the past, there was two main types of grafts. Surgeons would either take the patellar tendon, cut off a small piece, and make it the new ACL, or they would actually go to the hamstring and take a small piece of the muscle and make it the new ACL. What they realized, however, is that there might be a third option that is a better fit for the athletes that want to return to jumping, like me. And that is actually taking a piece of the quadricep tendon and making it the new ACL. For both of my knees, this is the case. Here's a picture of both of my knees. This large vertical scar here was the excision site to take out a piece of the quadricep tendon. Here, this is a very similar incision, but it's horizontal to also extract the quadricep tendon. So while that quadricep tendon was actually more advantageous for me going back to a jumping sport, there was one major consequence, and that was difficulty in refiring my quadricep again.
So as Jay mentioned, after her ACL surgery, she found it really difficult to kind of refire her quadricep again. And I was really curious as to why this was the case. So marked weakness of the quadricep muscles are actually quite common following things such as knee injury, post-knee surgery, or even in patients with just arthritis. And this has many implications, as Jay kind of mentioned in her TikTok. And this includes extension deficits, gait abnormality, quadricep atrophy, poor function, dynamic instability, pain. Pain is a big thing, persistent knee pain, as well as the chances of getting early onset osteoarthritis. So upon doing some research, I realized that the quadricep activation failure after ACL reconstruction is simply not just a case of isolated local instances related to atrophy. However, it's actually attributed to a process called arthrogenic muscle inhibition, or AMI, which is how I'll refer to it for the rest of this podcast. So AMI is actually a process in which the quadricep activation failure is caused by neural inhibition. So in Jay's case, her graft was actually made from the quadricep tendons. However, I was kind of surprised to find that quadricep weakness is a common occurrence with individuals with injuries or surgeries, even if it doesn't exactly relate to their quads. It's also been observed in other muscles surrounding the knee, so that includes the brevis muscles, the soleus, the fibularis longus musculature. And what I found after doing a little bit more research is that AMI is a presynaptic ongoing reflex inhibition of the musculature that surrounds a joint. So it's actually a natural response that's generated by the human body to protect the joint from further damages. So what I found was that the mechanisms for this inhibition are actually not understood that well. So there has been a lot of proposed hypotheses. Some are more accepted than others. However, some of the things that I found was that there was alterations in muscle resting motor thresholds. There was also changes in the discharge of sensory receptors in the knee area, as well as altered spinal reflex excitabilities. And I found the group 1 non-reciprocal inhibitory pathway coming up quite a bit in my research, as well as the flexion reflex and the gamma loop, and an interesting case of abnormal cortical activity. So I kind of wanted to spend a little bit more time looking into these mechanisms of action and seeing how that kind of leads to muscle weakness. So although AMI is a relatively new topic in the literature, its basis actually traces its root back to quite a few early anatomical studies that really looked at that connection neural connection between ligaments and muscles within joints. And what I found was that there were numerous studies that looked at showing how joint integrity is directly linked to muscle activity. So I remember seeing one study that basically electrically stimulated the ligaments around the knees, and what they observed was that there were responses in the hamstring, there was neural activity in the quadricep muscles, all those muscles around the knee. Many of the studies also showed changes in showed how changes in ligament tension could actually trigger reflexive muscle contractions. And that kind of acts as proof that ligaments can control the surrounding muscles through their reflexive motor control mechanisms. So the initial belief, and this I'm finding to be the most popular belief as well in the literature, is that AMI is primarily a reflex issue, and it's caused by inhibiting the alpha motor neurons in the spinal cord due to kind of that altered afferent signaling from that injured joint. So I kind of said earlier on that AMI was found to be a protective measure, which I actually looked into furthermore because I found that statement really interesting. So essentially, with reflexive inhibition, I'll give an example. If we imagine stepping on a Lego, the immediate withdrawal of the foot is a reflex, right? However, with AMI or reflexive inhibition, one of the things that you find is the reflex becomes persistent, hindering muscle function even during controlled movement. This theory kind of builds on the idea that many therapeutic exercises are less effective when the motor neuron pool is kind of inhibited. So in some of the studies, researchers actually mimicked joint injuries to kind of see the effects of altered joint afferent inputs. And they looked at things as joint swelling, which is known as a fusion. They also looked at pain and loss of mechanoreceptors on muscle function. And what they basically found was that joint swelling increased the recruitment of specific nerve fibers, and this kind of led to that inhibitory effect on the alpha motor neurons in the spinal cord. Pain also had a similar inhibitory effects on the same neurons because of its like specific nociceptor activations. So as I was talking to Jay, we also came across the topic of cysts. I looked into some studies and found that even injecting small amounts of saline in the knee joint could actually lead to reduced motor output and spinal reflex excitability. There were alterations in many different afferent stimulations, which included type 1B, 2, 3, and 4. However, what really caught my attention was the change in 1A afferent input from the muscle spindles. That was also impaired, and that was also found to kind of contribute to AMI. So 1A afferent nerves are actually detect muscle length changes internally. So with AMI, what you have is a gamma motor neuron dysfunction. And what this impairment will do is that it will actually reduce the co-activation of alpha motor neurons. And this lack of internal regulation may actually increase the risk of re-injury and joint instability. And this is something we saw in Jay's injury as well. Talking about Jay's injury, what I found particularly interesting was her comment on how her left quadricep muscle basically overcompensated for her right. So reflexive inhibition has also been shown to be a bilateral phenomenon where it affects both the injured limb and then the contralateral non-injured limb. So while AMI really negatively affected Jay on her right joint, she did have a systemic response, which I found interesting, affecting her left joint as well, which kind of explains some of the factors that lead to that higher risk of re-injury in her non-injured leg. And we did find that that was the case. So kind of shifting gears now, alongside reflex inhibition, what I found to be what I found in the literature to also be a significant source of AMI was the loss of mechanoreceptors. So at the spinal level, we have afferent sensory neurons from the joint mechanoreceptors as well as proprioceptors and nociceptors. So ligament damage actually disrupts the sensory information reaching the brain. And these are crucial for the muscles to respond appropriately during movement. I've discussed deafferentation with Shreya quite a bit from our class, as some of her research focused on this. And I also discussed this in the first episode of Muscle Strength. So if you want to learn a little bit more about how neuromuscular changes results in changes in strength. Definitely check that out. But the point kind of is that deafferentation, especially for loss of, for example, mechanoreceptor input or proprioceptor input, does increase that AMI and also does in some ways influence muscle atrophy. And this could actually be explained. This could actually explain Jay's intense level of muscle mass loss, which I found interesting. I think what's important to keep in mind is that the brain is a dynamic organ, which kind of adapts to the changes in sensory input. So even after knee surgery and her knee injury, the even if like the reinnervation occurs, the new connections are likely impaired and don't actually result in the same neural signaling as before. So the brain will receive altered signals from the injured joint, and this can lead to decreased activation of the motor cortex or make it more difficult for individuals such as Jay with her injury to refire her quadricep muscles. So, kind of in the case of Jay's injury, her surgery itself likely disrupted the quadricep muscle, which is a major muscle group responsible for the knee extension and stability herself. As she kind of mentioned in her TikTok, her repair was actually a graft from the quadricep tendon itself. And this inherent weakness would have caused the perfect breeding ground for AMI to kind of take place. There would have also been enhanced sensory loss because of the disruptions to the nerves and proprioceptive receptors within the quadricep muscle and that joint overall. So to summarize my discussion with Jay, I found it to be highly enlightening, and unfortunately she wasn't able to join me on this podcast, but I do want to say that I learned a lot within this process. And I think her injury serves as a great example of how interconnected the mind and muscle connection really is, and overall the body itself. It also showed how crucial it is to develop effective therapeutic strategies and treatments for AMI. So I'd like to thank Jay for being so open to having this discussion with me. And that is all for today's episode of Kinesthetic Knowledge on Record. I'm your host, Isha, and I will see you next time.